Good afternoon. My name is Dan Marzano, UBA Senior Manager of Strategic Solutions. On behalf of United Benefit Advisors and Allied, I welcome you to today's presentation in the UBA Employee Benefits webinar series. Today's topic is enhancing employee benefits through the self-funded model. Our presenters today are Dan McCarthy, Senior Vice President of Sales, and Steve Savanna, Senior Vice President of Sales. Dan McCarthy has over 20 years dedicated to self-funded health benefits administration. He combines deep industry knowledge with unparalleled expertise, making him an invaluable asset to both the Allied team and the clients they serve. As the Senior Vice President of Sales, Dan's proficiency extends to crafting custom benefit packages and delivering deep into innovative medical management and cost containment solutions. Steve Savanna has dedicated his entire professional career to helping employee benefit consultants simplify the creation of custom self-funded benefit packages for their clients. With over a decade of experience at Allied, Steve has provided countless employers with the best benefit options at the most affordable cost. Gentlemen, the floor is yours.
Perfect. Thanks so much, Dan.
Thanks, Dan. Appreciate you introducing us, and we'll get started. We've got a quick introduction and agendas. As Dan mentioned, I've been with Allied 21 years now. Steve has been with Allied how many years now?
Just over 12.
Just over 12, thanks. And I was fortunate enough to find Steve and hire him. So super excited to have him on the call with us. We're going to talk a little bit about difference between bundled versus unbundled solutions today. We'll talk about who we are as a TPA, being in the industry for over 43 years now, being independent that whole time. We'll talk about some innovative medical and cost management solutions specific to us. And then lastly, we'll talk about Allied Digital. And then we're going to open up the floor to Q&A, hopefully at the end. So we'll move efficiently. As we know, everyone's busy in the fourth quarter. First thing we want to talk about is really the difference between bundled ASO or insurance company models versus unbundled. And the easiest way to do that is to compare it through buying a home from a home builder where you had a set number of plan designs and options, and you really didn't have flexibility. So limited plan designs, limited network options, and limited flexibility, largely standardized throughout. And then one provider provides all of the different components within a health plan. So difference being unbundled and kind of building your custom home, it's not like, okay, we just take the given roof, the given electrics, the given closets, everything becomes customized. So when we go in an unbundled model, we have the ability to select the network. There's always multiple networks to choose from to evaluate who the best is from a disruption and discount standpoint. Also, from a stop loss perspective, who's the best stop loss carrier for your particular risk, dependent upon the features that the stop loss carriers offer. In recent years, we've seen an explosion in the captive model, and there's various versions in the captives that the employer has options to. So there's a whole lot of education that goes around unbundling. And then from a medical management standpoint, another set of variables that we look into, the PBM, and then also point solutions partners. So when you work with an unbundled solution or a TPA, an independent TPA, it's a different experience in that all of the different pieces you're using to build your home or your self-insured model are your own choice. And all of that comes through data analytics and working through the right consultants to say, what's the best fit for us? And then as time goes on, as you live in your home or your self-funded plan, you have the ability to switch out components or make updates to that model. So a lot more flexibility. With any administrator that you choose to work with, the most important part of the decision-making process is putting the different solutions or pieces together. So having the member services and care solutions, the technical infrastructure and analytics, the reporting piece, and then the administrative services piece, all bundled under one model. So for that employee experience, they simply have one provider. They know who to call, they know who to get their answers, and they've been educated throughout. So that's just a little bit about unbundled versus bundled solutions. I'm going to have Steve jump into kind of who Allied is, and then our scope of services.
Perfect. Thanks, Dan. I'll show you of Allied before we jump into really the meat of our discussion today, which is the medical management and cost containment, some of the unique components of a self-funded environment, which is why most employers eventually gravitate to this type of an arrangement. The idea that I want to hopefully leave everyone with is that this is not designed to be an Allied commercial. A lot of what we're going to talk about today is programs that Allied has developed over many years, but these are ideas that we want to plant within the folks watching us today, within your consultant partners, your carriers, administrators, things to really think about. And from our experience, a lot of these medical management pieces are foundational to what we do. So start with that as kind of the lens to view this discussion through today. As a high level view from Allied, today Allied's the largest independent administrator in the country. We're not owned by a network. We're not owned by a carrier. That's going to become very important when we start talking about some of the more unique cost containment, medical management pieces, and how those interface within a health plan. We're based in Chicago. That's where I'm based out of, but national in scope. We have clients and field and service offices across the country. And that's spread out across a variety of different network arrangements. Allied is an Aetna administrator, an Anthem Blue Cross administrator, Cigna. Beyond that, at this point, more than 45 other PPO networks nationally, just by virtue of kind of what's most appropriate for our clients. And so, again, from an independent administrative standpoint, Allied has no vested interest in any one network partner. We're tasked with ensuring that we're processing claims accurately, and we're helping advise on who the most appropriate plan partners may be. And so we have a lot of insight to give there, but by no means are we married to one particular vendor. Same is true on the pharmacy benefit side of things. We have several logos illustrated here, but there's more than 35 different PBMs that Allied trades with today. Also on the reinsurance side, on the stop loss component, as Dan mentioned, there's a variety of different players in that space. Ensuring that you're working with a partner that can help you navigate those pieces, that's foundational to this type of an arrangement. Won't spend a ton of time here, but the point solution market, I think at last count, we're over 150, close to 200 different point solutions that Allied is trading with today. And again, that kind of goes back to the flexibility and ensuring that we're providing an integrated model for our clients, but really being sensitive to vendors you may already be working with today, things that may be working, whether that's on the eligibility and payroll side of things, advocacy and concierge. We'll spend a little bit of time talking about this. I think most folks on this call have probably heard about some of the changes nationally within the transparency and coverage regulations. These are incredibly important pieces, and having a partner that's willing to work with vendors and at least have a collaborative discussion on who's most appropriate, this is a very important piece of what we do. So with that, I want to spend a few minutes kind of getting into really the focus of our discussion today, which is kind of where we see the progression of our healthcare system in this country. I think most of us are familiar with this. Anyone that's involved with administering or managing a healthcare plan, this is really true stats of any major medical plan arrangement, whether it's fully insured or self-funded. It's about 4% of the population that's driving close to 50% of the spend. And so a lot of what we're going to talk about today, it's focusing on one of the biggest drivers of healthcare costs within any major medical plan, which is the large claimants. And again, I want everyone to understand, look at this through the lens of we're trying to ensure we're balancing the member experience as well as ensuring healthcare can remain sustainable, right? Since I've been at Allied over 10 years, I can tell you we used to see $1 million claims across our clients, maybe a few times a month. We now see $1 million claims usually a few times every week, and that's in a decade. And employers are really holding the brunt of that increase in claim costs. Pharmacy costs are the same thing. We're seeing, depending on the actuary you speak to, between 10 and 15% annual increases in pharmacy costs. This is not sustainable. And so a lot of what we do, if we're going to really move the needle, it's not jumping from Blue Cross to Aetna to Cigna to United Healthcare and back and forth, chasing 5-10 percentage points of savings. It's what are we doing here? And how are we doing it in a sensitive way that doesn't completely upend the member experience? Right? The whole purpose of what we're doing is to attract and retain talent, retain employees. If all we do is focus on the cost, we're going to negate the member experience and we're not going to achieve our goals there. We've seen that with some of the reference-based models in the market, not discounting those arrangements, they have a place, but those can be more challenging from a member experience standpoint. Again, it also doesn't discount other strategies. Telemedicine is incredibly important, versus urgent care utilization. These are important pieces. I'm not going to discount them. But when you have 4% of your population driving 50% of your spend, this is where we need to put our time and attention. So or kind of play into how we view this, but again, this is not just specific to Allied. Keep this in mind when you're talking to your current carrier, your administrator, your consultant partners. Allied Care is Allied's kind of our utilization review and medical management process. Dan is going to speak momentarily about Allied Advocate. That's one of the best things Allied does as an administrator as far as managing high dollar activity within a PPO network arrangement. I'll come back and explain a little bit about how we take traditional case management several steps further. Every major medical plan, fully insured or self-funded, has case management as a component of that plan. I think most of us can agree it falls woefully short in actually impacting outcomes and providing value. And we recognized that many, many years ago and started to build out our own internal team, Allied employees within that space, to really take traditional case management several steps further. And we'll spend time talking about that. Behavioral health and wellness, we won't have time to cover these today, but again, I think most of us are familiar with the value of having a good behavioral health program and wellness initiatives as well. So before I turn it over to Dan, I just want to set the stage a little bit with some of how these strategies work. I know this is kind of a confusing slide. I'll do my best to walk everybody through it. The way we want to look at this is really comparing traditional PPO plans, right? The Aetnas, the Cignas, the Blue Crosses, United Healthcares of the world, versus some other payment or reimbursement methods. This is ultimately what drives costs within a health plan, how a claim is actually paid. And so if we think about the commercial market as Blue Cross, Aetna, Cigna, and so forth, and we think about a dollar claim, on average, the discount you're getting from those networks, about 50 or 55%. And that's what you buy. When you buy Aetna and Cigna and Blue Cross, you're buying access, how many doctors and hospitals are contracted with that network, and you're buying their discounts, what they've negotiated within those contracts. And so it's an incredibly important part of that discussion. We find in a lot of areas, there's almost parity between most of them. So it's not the only piece to be focused on, but on average, probably somewhere between a 50 or 55% discount nationally. If we were to compare that with federal Medicare, you're about 78 to 81%. That's a big spread. That's a spread that will move the needle from a claim standpoint in a significant way. And then again, I think most of us on this call have probably heard the term reference-based pricing. Really, the way to simplify this, it's an alternative payment method. It's different than a traditional PPO contract that we're all used to. It's using usually a fee schedule that's common in the market, which is Medicare, plus some additional percentage on top of that to try to increase provider acceptance. When we do that, when we pay Medicare plus 50% or 40%, we're still driving savings, but you can tell we're kind of squeezing that gap a little bit more between a traditional PPO network and a plan that's paying at 100% of Medicare. So if that was helpful, I'm going to turn it back over to Dan to kind of walk you through our Allied Advocate strategy and how these pieces come together.
Great, thanks. So what are we talking about here? Because we're talking about a lot of different concepts, and the key thing that Steve is driving home is we now know that the bulk of our claim costs are driven by those 4% of our members that drive 50% of our costs. So here introduce the Allied Advocate. Now, Steve gave you some background of how the pricing differential works within Medicare and PPO. One thing's for certain, we know that we have about a 30% additional savings if we pay claims at Medicare allowable. So what the Allied Advocate does is it specifically targets for members in that claim category that drive the bulk of the costs. And what we want to do is provide all the tools and resources for those members to get their healthcare managed appropriately. At the same time, we don't want to pay the full boat or PPO discount. We want to pay a seriously discounted amount through the Medicare allowable. So what we do for that particular program is we incorporate plan language that says for these particular claims, we're going to pay at Medicare allowable. Now, the categories for those claims, which is what Steve is showing now, are ambulance, dialysis, inpatient hospital, outpatient surgery centers, and high-cost physicians. Now, every network isn't the same as far as what particular prongs we can apply. With rental networks such as PHCS, First Health, and regional such as Providers Care Network, we can use every single prong. With Aetna and Cigna and Anthem now, we can use dialysis and infusion therapy. So what does that enable us to do? It enables us to pull those claims out from traditional PPO discounts and then pay at that Medicare allowable. And what we're generally seeing from a savings standpoint, here's our 22 statistics. We had $275 million go through that program. The PPO was $171 million. What we actually paid on those claims was $65 million. So what you see is a savings of over $100 million. Now, granted, that's spread across our block of business, but if you're the employer who just saved close to $1 million on one dialysis claim, that directly affects your bottom line in your stop loss renewal. So the program is innovative in that it's not intrusive of your PPO contracts, but at the same time, it's going to drive those additional savings that could be huge dollar amounts. Now, what typically happens, we have providers accepting 63.4% of the time at a flat Medicare discount. Now, that's not a Medicare plus, that's not a Medicare 150 like you'd see in reference-based pricing, but simply flat Medicare. That's where that 30-point delta exists from the PPO allowable and the Medicare allowable. Then we negotiate 2.2% of the time. So less than what the PPO allowable was. And lastly, if we can't get anywhere with our negotiations, it's going to fall back to that PPO allowable. So you always have this safety net or backstop. Unlike a reference-based pricing, you're going to have that PPO model to make sure that your claim gets settled. Now, throughout the process, the claimant has an allied advocate, which is a personal healthcare advocate that will speak on their behalf in the event that they ever have any issues from a provider, from a balanced billing standpoint, or just to manage their general care. Because chances are, if that claimant is in that 4 to 5% that's driving 50% of the cost, they're seeing multiple providers, they have multiple conditions, and they need help managing their healthcare, which, as we all know, is challenging in today's marketplace. So it truly is a benefit for not only the employees that go through the program, but also the employer from a cost saving standpoint. Just one case study that we'll show you is on one dialysis claim, we saved $936,000 for an employer. Now that's absolutely huge because for that employer, they save, the stop loss carrier saves, and you're going to look at a favorable stop loss renewal, outside of any type of laser. So we know these programs have direct impacts to current claim situations. Oftentimes when Steve and I are working with consultants and brokers, we get claim detail if they're already self-funded and they have that access, and we can show additional savings to what they're currently achieving through the Allied Advocate program. Now I'm going to turn it over to Steve to talk a little bit about enhanced case management and how we manage those high dollar claims just outside of the standard Allied Advocate offerings.
Perfect. Thanks, Dan. I would just add on the Allied Advocate piece to echo Dan's points. What's unique about it, kind of going back to the earlier comments about making sure this is sustainable, it's designed to really function behind the scenes. This is not, Allied Advocate's not a program we talk about at open enrollment meetings. It's something that is initiated whenever we have, and again, we're talking about a very small percentage of the group, 4%, it's a handful of members, but the big ones, the ones that are driving the bulk of the cost. And so the idea is that this functions really behind the scenes. This is Allied negotiating on behalf of the plan with the provider. And if we're successful, great. We're driving savings to the plan, to the stop loss carrier, which translates into more competitive renewals. And then we're normally able to wipe out the members' out-of-pocket expense as well, since we're paying below the PPO allowable rate. And so those are the advantages. And if we fail, to Dan's earlier point, we're paying up to the PPO allowable rates in the event we're unsuccessful. That's what keeps this sustainable. The worst case scenario was we're paying the claim the same way we would have had this program never been in place. That's what ensures that this is not a noisy So with that, we talked a little bit about this earlier, but enhanced case management and thinking about a more comprehensive, more holistic way for us to manage large claim activity that requires a little bit more handholding. These are the areas that this team is constantly evaluating. There's a host of others, but these are some of the core areas that the team is looking at. I won't spend time on each of them, but some of them that can be incredibly impactful: frequent excessive ER visits, behavioral health and substance abuse, site of administration is a very big one. And so within those, so let's just stick with those three for a moment. Site of administration is a very big one that we're seeing across the board. I think again, for those of us that have seen behind the scenes of some of the claim costs within a health plan, if you've seen infusion therapy done, whether that's an MS infusion, Crohn's infusion, chemotherapy, what we're often seeing is hospital systems buying those medications, marking them up significantly within the terms of their PPO contracts, but that gives them a lot of room to do so. The markups can be 10 to 12 times more expensive than what you would get for that same drug if it was administered elsewhere. And so that's a challenge, right? We have employees that are being told by their provider they need to have this infusion done within a hospital setting on an ongoing basis. And it's costing the plan 10, 12, 15 times more than that same infusion being infused right down the road at a standalone infusion clinic or at the member's home with a clinical nurse without having to even go to the hospital. And so we see this type of behavior frequently across the board. And so having partners that are able to facilitate that transition of care and do so in a sensitive way, that's a key. We're not the only ones doing this work, I'd add. There's other vendors in the market that are doing similar work. We feel like we have a good story to tell since we're also administering the entire health plan. But ensuring that we're having communication with the member and then the provider is key for that, and ensuring that we're doing this in a way that's sensitive to the member. Will allow that first 1 to 2 infusions to be done in a hospital setting under this prong of the program, because oftentimes you're going to need to be evaluated and monitored by a provider in a hospital setting if it's the first time you're getting the infusion. After that, it's typically appropriate to transition care. And so that's usually when our team will step in. But the cost difference can be substantial. So this gives you kind of a sense for how we're going about identification and going through this process. Our team is constantly evaluating, the prior authorizations, pre-certifications that are coming in, individual claims, to identify these situations that require more handholding and require a more sensitive approach. Internal and external referrals is another method for this. So that can come directly from our clients, from an HR manager that may be aware of a member going out on FMLA before Allied is ever aware of that. That's a perfectly appropriate way for our team to at least initiate and start that evaluation period. When they're evaluating, every case is very unique and very, everything is different, and that's okay. It just requires us to be having a very fluid approach with how we monitor and evaluate. And so our team is evaluating all the information we have. We consult with our panel that's made up of our medical director. We have an in-house pharmacist. There's clinicians, social workers that are part of this team, and they develop that initial strategy. If that means engaging with the member and the providers, that's the next step that the team will do. They'll develop kind of an assessment of how they're going to move forward and what's most appropriate. And then depending on what route we're going, we'll connect that member to resources. On an ongoing basis, that means monitoring that member's status, evaluate how successful it's been, and continue support as needed. So I wanted to include some case studies here because I think this is helpful to kind of illustrate how this can function in the real world. So this is one of my clients. This is a client that's based on the East Coast. I was involved heavily with this particular situation. So the member was getting an infusion done at the hospital. It was done every 21 days. This was for MS. The employee was actively working. They were doing great. They were going to continue on this for long term. It was a medication that was having a profoundly positive effect on their treatment. All our team did was have a connection with that member, made an outreach call to them, ensured that they knew that they had an advocate within Allied, questions about bills that they've received that they don't understand or navigating their care. This is a direct resource for them. In addition, we kind of made it clear to them that this is not the only option. You don't have to have that infused medication only done at the hospital. There may be an alternative. What we found was that there was an ambulatory infusion clinic that was right down the road from the member's house. I think it was less than 2 miles, as opposed to the 30-minute drive to the hospital that she was doing every 21 days. Just that change, and that was not a big lift on Allied or anyone to transition that care, but it did involve having to make outreach calls and being thoughtful about the transition. That one change resulted in $6,000 less per treatment. So when we started this in 21, it was about 91,000 in savings to the plan, and about 119,000 in 2022. So these are the types of situations that our team is looking at. And that's the difference between, in this case, it was the Cigna network and moving that infusion outside of the hospital. One member, savings over $100,000 in 1 year. Another case study I'll share with you, this kind of goes to our coverage evaluation prong of this program. A lot of folks aren't familiar with this particular component of Medicaid, but regardless of of a family's income, if a child is born premature, depending on their gestational weight, they often can qualify for state Medicaid. In this scenario, so this is a colleague of mine, but this is their client. Our enhanced case management team made an outreach to the family right as the child was being admitted into the NICU. They built a relationship with the family just to make sure that they knew that they had resources on our side if any questions came up. And they really helped them evaluate their options. As the child was there for several weeks and they were having these discussions, it was trying to determine what the most appropriate route was for the family. Moving the child onto the health plan within 30 days, the employer's health plan, or evaluating alternatives. And the team was able to explain to that member that the child did qualify for state Medicaid. It would not impact their care in any way. That hospital was a children's hospital that accepted state Medicaid. In that savings difference to the member of then their out-of-pocket and difference in their employee contribution, if they felt that that was appropriate, our team could help facilitate that. And the member made that decision that absolutely they wanted to do it. That one change ensured that that entire NICU stay did not impact that employer's health plan. It was a win for the member, first and foremost, and secondarily the plan. But just that one, those small discussions we had over that period of time has driven more than $300,000 in savings just for that one member. So that's the lens we kind of view these types of strategies through. Highly case specific when it comes to enhanced case management. There can be a lot of nuance here, but really having a team of clinicians and counselors in some cases, a medical director, pharmacist, to step in and do some additional handholding, things that we don't typically see with traditional case management. All right, I know we've thrown a lot at you in a short period of time. Really briefly, as we wrap up, I do just want to touch on some of what we're doing from a member navigation and digital experience. So Allied has spent the better part of the last couple of years redefining what our member experience looks like. And that's beginning in 2024. That means we're launching a new revised member experience, a way that really integrates all of these components we've been talking about. So all the Allied portal detail needs your ID card, your claims information, your EOBs, all of that being easily accessible, but then also embedding the compliance components as well. So the employers that are on the call that have seen some of these changes, they're significant. The Transparency and Coverage Act has made a whole host of requirements on group health plans. Things like ensuring that cost estimations is a component within your member experience. But then taking it a step further and kind of combining some of these disjointed tools that we all have to navigate, right? You're using Allied to track your claims experience and view your ID card and so forth, but then you're using a different network for the provider search. You're using the pharmacy benefit manager's website to try to manage that piece. There hasn't been a lot of great tools that can integrate all of those pieces together in a seamless way. And that's what we're trying to do with this Allied digital experience. Cost estimation is a component of that as well. So being able to estimate in advance if you know what you're going in for, if you know it's a minor surgery, being able to tell exactly what that cost is in advance of service based on the provider you're going to see, the plan that you're enrolled in. All of that is housed within our Allied Digital app. Care navigation is the other point as well. So I kind of mentioned all of these, allied advocate, enhanced case management. Whenever those situations are initiated, it's often allied picking up the phone and calling, sending letters directly to plan members to initiate. This also gives us a way to communicate directly through the app. So any members that are registered for the Allied digital experience, they'll be able to get push notifications directly from our case management team and from our allied advocate team, which gives us a much bigger advantage of being able to reach people more efficiently. I'm going to turn it back over to Dan, but I appreciate everybody's time. Thank you again for the time this afternoon. Oh, Dan, you're on mute.
Thanks, Steve. Yeah, I'll wrap up and then we'll get into a couple questions because we did have a Q&A question. So, we talked about a number of different concepts today. So unbundling versus bundling. Our value is obviously in unbundling. We think there's infinite solutions and ways to manage healthcare costs. We talked about Allied Advocate, a way for us to manage claims within a PPO plan design while utilizing best in practice pricing. And then we talked about enhanced case management to really provide us additional savings outside of what you'd see from a traditional PPO. And then lastly, we talked about navigating healthcare through Allied Digital. So a lot of different moving pieces. Steve and I's job is very unique in the fact that we get to work firsthand with the consultants to design the ultimate health plan for that particular employer that we're working with. And then along the continuum of that health plan, we get to make tweaks to enhance it. So I know I still have the first client that I ever signed up at Allied, and they're over 20 years now. I was about to say the client, but I didn't. So excited to continue to work with the UBA advisors on their specific risks. I think there's a huge opportunity for us in today's marketplace to get into kind of the niche marketing of things. Where can we have a particular impact on a particular health plan? So very excited to continue our relationship with UBA. On the Q&A so far, I had I have two questions in, and then Steve and I will kind of tag team these questions. The first one is, how do your CMs convey the sense of care for the employee while also sharing the impact of the bottom line of the company without seeming like a salesman or casting the employer in light of a cheapskate? I worry about the perception of the employee while also worrying about the planned impact. I think that's a great question, and I'll give you a specific scenario that I was in. I work with an employer group that manages restaurant chains throughout the Midwest, and they had an employee similar to that premature baby where this employee gave birth at 26 weeks. We knew it was going to be a six to seven figure claim. We had our social workers speak directly with the member. She was Medicaid eligible, and moving her to Medicaid was a better situation for her and the baby, and the fact that she got 100% coverage and zero out of pocket. So every solution for us is different in that we know that we have to handle it with kid gloves. In that particular situation, we saved an easy 6 to 7 figures, and never did we seem like this, cheesy sales organization. We were helping the member, and then we were also helping the plan. So it has to work both ways.
I would just add to that point, the process stops. So part of that process of identifying a member that's going to potentially be a good fit for enhanced case management, if it's a scenario that only benefits the plan but not the member, that's not something we're going to pursue. There are situations that may not have any impact directly on plan costs, but impact the member experience in a significant way. The team is constantly evaluating those situations. I had one recently where it was a dependent of an employee that's on the plan. Dependent was not, and there was an auto accident that occurred that was impacting the performance of that employee. The HR team reached out directly to us to ask if we had any resources, and our case management team was able to help. It's not designed to be plan first, member second. It's member first, and in the event that we're able to move the needle from a member experience standpoint, from their own personal finance standpoint, and there's a benefit to the health plan, those are the situations that we'll move forward with.
Another question came in and says, how do you manage a very high pharmaceutical specialty drug that is life-sustaining and not likely to move from the plan and the employer? And that's another kind of specific situation and where we'd have to dive into it. I think everybody's aware of the patient's assistance programs that are available and the carve-outs programs that are available, and then also the international sourcing. So a lot of the work that we do is having that discussion with the employer and then also doing research on behalf of the employee to see what additional resources are available for that specialty drug. Okay. Any other questions? And by the way, thanks for asking me questions. We appreciate it.
Perfect. Well, we appreciate the time, everybody. Thank you again for spending the last 40 minutes or so with us. And we look forward to speaking with you again.
Thank you, Steve and Dan, for your thought leadership and sharing your expertise today. We'd also like to thank all the UBA partner firm employees for taking time out of their busy schedule to come on to this webinar. And just as a reminder, our next webinar next month will be on a health plans guide to the Consolidated Appropriations Act presented by CXC Solutions. And the date is November 21st. Thank you again and have a great afternoon.
Thank you all.